The next topic is going to be an update on hypothyroidism. And it's a great pleasure to introduce a friend and a dear colleague at Dubai Health Authority, Dr. Jalal Nafach, who is also a consultant endocrinologist. He's double American certified. He's board certified in endocrinology at the University of Nebraska, and he's certified in internal medicine at Michigan State University. Dr. Jalal, we're looking forward to a great presentation.
Thank you. So, thank you for all being here. I see everybody's kind of tired. I'm the only one that's kind of energetic here. I drink so much energy drink, actually. So anyway, typically most of my talk is diabetes. This is actually a little bit shifting gear. Am I the slide from here, right? From this PC. All right. So again, I work in DHA, so this is not a DHA presentation per se. I always put this over and over and over. So we're going to move first for the hypo. We're going to go over things that I think is kind of important. The hypo, the subclinical hypo, which is very vague, and then the pregnancy, which is, I think, is a lot of time, in a way, mistreated. So there's three kinds, if you want to think about it as hypothyroid. So there's what we call clinical hypothyroid. Now, again, clinical doesn't mean necessary symptomatology. So clinical hypothyroid is actually when you have elevated TSH and low free T4 or low thyroid hormone. So this is the overt, if you want to call it. So subclinical is when you have a normal free T4 and you have elevated TSH. Now again, what's normal, what's elevated will be later. And then you have mainly the secondary, which related to usually pituitary dysfunction, where your thyroid hormone or T4 goes down, but your TSH, your brain signal, does not respond appropriately. And in this case, this is people we treat only based on the T4 level. We don't treat based on the TSH. I see a lot of patients come to me, and their TSH is low, so sometimes the physician reduces their dose. You cannot treat based on the TSH because, again, the pituitary does not respond appropriately, and so you have to do based on the T4 level. I mean, this is the way we're going to look at it. Now, the problem with the thyroid is if you know, typically people will come to you with complaint. Now, again, this slide looks very full, and this is actually 50% of the symptoms of low thyroid. Now, the typical symptoms is fatigue, dryness, weight gain. Typically, the weight gain is fluid shift more than anything else. The majority of people who are found to be low thyroid because they complain of weight gain, it's not really related to the thyroid, and we have to reinforce the patient. Hair loss, 90% of the women will complain of hair loss, so we can screen 90% of the women. Fluid retention, dryness, constipation, and heart failure, and thyroid goiter, and on and on and on. So what I'm trying to say is the symptoms of thyroid is very vague, and it's very hard to really pinpoint on it. I mean, if you're a cardiologist, you get a chest pain, you know, again, you go through this. You rule out cardiac disease, you look for, you know, pulmonary embolism, you look for dissection, I mean, this area. Symptoms of thyroid are very vague that you really don't know if it's thyroid. And so anything you look at, you have to take it, you know, with a degree of grain of salt. You cannot just say, your symptoms exactly low thyroid, and that's the way. When I was in the US, I used to get a lot of people who have this online questionnaire, and they go and they answer it, and the majority will answer positively on at least 5 to 10 of the symptoms. I mean, everybody will feel fatigue at some point. Everybody, well, 85% of us are overweight anyway. So, I mean, if you're going to look, all of us could have low thyroid. So, at the end, you have to remember you need to screen people, and you have to, there is a criteria who to screen. But at the end of the day, most of the guidelines advise you to screen everybody between, you know, 3 to 5 years irrespectively anyway. Now, one thing we have to remember that what's normal TSH is very controversial. Most of the lab, what do? They get 100 people or 200 or 1,000, they draw blood, and they decide that there is a, you know, bell-shaped curve distribution of TSH, and so that's normal and that's abnormal. And that's not really the way to look at thyroid, because those people who are checked for a normal range of TSH were not checked for goiter, were not asked if they have family history of thyroid disease, they did not have their antibodies checked. So you are going to have a lot of people with subclinical thyroid disease that are part of the normal group. This is the same thing apply, for example, if you look at testosterone level for women. It's incorrect because, again, When they draw blood, they don't ask them, how is your menstrual cycle? Do you have any hair growth, acne? So if you look at the testosterone level in a lot of labs, it goes up to 40, 45. It should be 28, 30. So again, what's normal range is very controversial. And I think at the end of the day, later at some point, we're going to have age-related TSH level. And the reason I'm saying that, younger people typically tend to have a lower TSH. As we get older, our TSH goes higher. And in older people, again, when I say older, it changed my perspective because as I get older, older has become older. So anybody over 75, 80 years old, it is totally normal to have a TSH of 6 to 8. Actually, there was a study on Ashkenaz Jews that, again, is a different allele, where actually the high TSH was associated with longer life. So what I'm trying to say is, don't look at it that, well, this is the normal range, this is normal, this is abnormal. Again, normal physiological may be up TSH of 2.5 to 3. Anything above it, you really need to look at the antibodies and people's symptoms. One other thing to look at is weight. So as we gain weight, leptin goes up because we're more leptin resistant, and actually our TSH goes up. And so this is one of data that actually show you that as we gain weight, we're actually having a higher TSH, especially in those with stage 3 obesity. When you have a BMI 40 or more, your TSH is normally higher. It doesn't mean necessarily you're underactive thyroid. So again, and it doesn't mean that's why this person is BMI of 40. Having a TSH of 5 or 6 does not make you have a BMI of 40. You can have a TSH of 30 and still you're going to get a little bit of fluid retention. So again, this is just to give you an idea what a normal TSH should be. Again, most of the lab use 4, 4.2. Again, younger population, you may want to use 3. Again, you ask people symptoms, questionnaire, family history, you may check the antibodies. Now, who should we be screened? Well, number one, anybody with high cholesterol, okay? And this is, I remember I worked on a case when I was in the US where a patient presented with severe hyperlipidemia. Patient was given simvastatin at that time. Patient did develop almost rhabdomyolysis with CPK in the 10,000. Really, at that time, patient has severe achiness, elevated CPK. He was referred to rheumatologist. Rheumatologist checked the TSH. That was the first time it was checked. TSH was over 100. The patient really did not need simvastatin. All the patient needed is thyroid replacement therapy. So my advice is before you start any statin, you have to check TSH at least. You have to screen patient for low thyroid because this is a common reason for hyperlipidemia. And even a TSH of 6 could make a difference to 6 point in the cholesterol. Of course, hyponatremia is one of the things you look at. Anemia, you look at. Anybody with multiple autoimmune disease, you have to think about it because, again, they have a higher chance of having autoimmune disease, prior thyroid disease. Family history is very important. If you have a female with thyroid disease, her offspring girl, so if a woman with underactive thyroid and she has delivered a girl, her girl will have almost 50% chance to have low thyroid at some point in her life. It doesn't mean you check the thyroid every month, but you just need to know that. Down syndrome, again, we screen them regularly because they're very common to have underactive thyroid. Turner syndrome, and then again, pulmonary hypertension, multiple sclerosis, again, is autoimmune disease. Pituitary disease, again, of course, that's not a brainer. And then there's a lot of medication that interfere. The most commonly used really is the amiodarone and the interferon more than anything else. So amiodarone is a whole big subject. Again, some patient will have hypothyroid, some patient will have induced thyrotoxicosis with the amiodarone, and actually the thyroid dysfunction with amiodarone can happen more commonly even after stopping the drug. So if a patient presents to you with thyroid disease, underactive or overactive, if they have any cardiac history, you need to ask them, did you ever receive amiodarone? Because they could have stopped it 3-4 months ago and still their thyroid is dysfunctional from the amiodarone. And of course, if you do any nuclear scan, it's going to be negative because they have so much iodine on board from the amiodarone. So what's about subclinical? Now, subclinical is where is the majority of people I see now. I don't see a lot of really overt hypothyroid. This is 1950s, not 1950s anymore. Now, what's normal TSH? Again, younger, healthier population, especially female, especially at pregnancy age, those that they may get pregnant, you want to be preferably normal below 2.5 to 3. Now, I see patients sometime in the clinic for diabetes, let's say, and they have a little bit abnormal TSH, and they say, you know, make sure you don't get pregnant. They promise you they're not going to get pregnant, but they don't necessarily do that. So, you know, you may want to treat them to be on safe side, because you have to remember, majority of women do not know they're pregnant for at least 6 to 8 weeks sometime. They think it's one of their regular delayed cycle. And then you have to remember that the fetus depend on their brain development the first 13 weeks on the mother thyroid, where really the fetus thyroid is non-functional. So mainly the initial phase where there's the neurodevelopment, it depends wholly on the mother. So I think if you have somebody who may theoretically get pregnant, you may want to be aggressive. Again, this is not a guideline, this is kind of case by case. Now, of course, for pregnancy, there's supposed to be a normalized TSH, normalized free T4. Do we have that? No. Do we have that in DHA? Heck no. So you do it with what you have available. Now, do we have to care about it? Well, I mean, in any disease you treat, you have to treat if it causes abnormality. So the first thing is, again, subclinical hypothyroid can progress to clinical, usually somewhere between 2 to 4 or 5%. Of course, if you have a positive antibodies, use annual conversion rate about 4.5%. So you have positive antibody, you're more likely to become overt. You negative antibody, you're less likely. And you know, this is the way you're going to look at it. Now, there is some data. Again, you have to remember, this is not randomized double-blinded data. This is retrospective analysis. But at the end, on those data, there is a link between cardiovascular heart disease. Again, with the TSH over 10, there's about 1.8 hazard ratio. Heart failure, of course, for sure. And so any patient with heart failure, you need to screen them for thyroid, again, advised by cardiologist. Stroke, again, there is data to suggest increase in the stroke, especially in the younger population. Again, here you see the hazard ratio 3 to 4-fold. You don't have to remember the numbers, you just remember the idea of it. Of course, cholesterol. So even if you have, as I've told you before, TSH of 6, that's enough to raise your, total cholesterol from 216 to 223. You have a TSH of 30, you can run level up to the 250, 280. You have a higher cholesterol. And so you have to remember, anybody with high cholesterol, again, you need to check the thyroid. It is associated with increased risk of NAFLD and NASH. Is that important? Yes, because I think 60 to 80% of us already have NAFLD and NASH anyway, including myself. And fertility is important. Again, any infertile lady or any lady with miscarriage, she needs to be checked. It's very sad that I see women who had multiple miscarriages, multiple IVF, and they had not got their anti-thyroid peroxidase antibody. They spend 150,000 dirham, and this is not done. This is crucial. It has to be done. And in somebody who's trying to get pregnant, I would check both the TSH and the antibodies, because I would treat them totally different. Especially you have somebody who's taking the effort and the risk and the IVF, and you're missing a simple base rule. Now, when you have, again, subclinical hypothyroid, normal T4, free T4, elevated TSH. Now, what's normal TSH? I talked about it again. Typically, in a younger people, you may want to use the number 3. You can use up to 4.2 or the reference lab you are using. And again, older people over 80, normal TSH, again, 6 to 8. People with BMI 35 or 40, TSH is higher, about 5 or 6. So if you have a TSH over 10, what do you do? Well, we treat. Why do we treat? Because I showed you the data with increased cardiovascular disease, increased heart failure. It seems to be associated, at least on those data, with, again, TSH over 10. Now, do we have an interventional study to show reduction? No. Are we going to have such a study? The answer is no, because nobody is going to spend $200 million to prove this. They will tell you just treat thyroid because it's easy and safe. Now, what's about your TSH 7 to 9.9? Now, again, you look, it's very individualized. I mean, it depends on the patient. Of course, again, younger patient are much more aggressive. Older patient are much less aggressive. 80 years old, I'm not aggressive at all. And so if I have 80 years old with TSH of 8, 9, I may not do anything. I will let it go. We'll monitor him. And again, we check the antibodies. Why the antibodies? Because again, if the antibody is higher, I'm more likely to see this progress into overt. Again, we said annual rate about 4.5%. Now, if patients have symptoms, you may consider to treat. because that's, you know, again, you're trying to see if there's improvement in the symptom. So when you have a TSH between 7 to 10, you look at the antibodies preferably, and again, I would look at patient symptoms, how they feel, do I think the symptoms could be related to the thyroid, and then at the end, you're going to treat the patient and see their response from a perspective of symptoms. Not everybody with TSH of 8 will feel fatigue, and not every fatigued patient with TSH of 8, their fatigue is from the thyroid. They could be feeling fatigue because they have low testosterone, because sleep apnea, because they're depressed, they're not sleeping well. There's many reasons to feel tired. It does not have to be thyroid. And of course, not every overweight is from the thyroid. Again, it's not the thyroid. You have to reinforce that to the patient. Now, what's about TSH between upper normal? Again, I mentioned the upper normal is very vague as life can be, up to about 7. And then again, younger people, you're more, again, aggressive. Older people, typically you want to avoid treatment, again, over 8 years old, because again, 6.9 or 7 is what? Is normal for them. So if you have somebody who's 85 years old with TSH 7, let him live, leave him alone. Actually, you may help him live longer to stay this way, so don't treat them. Now again, if they have positive antibodies, they have goiter, there's a reason to think that there's an actual primary thyroid disease, then you treat them. I know most likely after this lecture you'll be more confused than you come here, but the whole idea of it is actually remembering, think about the patient as a whole and not as TSH as a number. This is the only thing you need to remember from the whole talk. Now, infertility is a big issue again, as I mentioned. If I have infertile lady with miscarriages, because patient with Hashimoto with increased thyroid peroxide antibody seems to have about 2.5-fold increased risk of recurrent miscarriages. You do not want to have somebody with recurrent miscarriage and not being checked for Hashimoto. It would not make sense. And again, those patients, especially if they have problem with their menstrual cycle, because again, if you have a woman with irregular cycle, what's the 2 tests you need to do before you say maybe she has PCOS? So PCOS, if you use the North American guideline, oligomenorrhea or even abnormal ovulation, and increased male hormone clinically or biochemically. So they can have acne, they have irregular cycle, their PCOS. But before you say that, you have to check 2 things. The most important 2 things, not testosterone, not DHA sulfate, it's TSH and 17-hydroxyprogesterone to rule out congenital adrenal hyperplasia. So this is the 2 things you do. You do TSH in the morning, and you do fasting day 3 to 8, 17-hydroxyprogesterone. Then, if you want to check other things, you can, prolactin, whatever. But again, it's a diagnosis of exclusion. You need to rule out those 2 conditions. Now, how do you treat patient? Again, it's a common sense. You have an older patient who have heart failure, have a heart disease. You start them small dose. You can start them 25. You can start them 37. 50 alternate with 25. Or you can start with 50. The whole idea, it depends on 2 things again, their weight, their TSH. The heavier, most likely they will need more. The higher the TSH, they need more. So if you have somebody with TSH of 6, maybe do 25, have TSH of 9, maybe do 50, and again, they're heavier, they may need more. The most important is you need to recheck them 6 weeks down the road, typically, to look at their TSH of 3 to 4. Now, what's about younger patient? Again, I depend, and again, here we're talking subclinical, I depend on not necessarily the full replacement. So if you have somebody with overt hypothyroid, so somebody come to you with TSH of 15, free T4, that's low, 0.7. What do? Well, you start 1.6 to 1.8 microgram per kilogram in younger patient. Of course, older, you may do it gradually. It's wrong to have somebody with overt thyroid and put them on 25 and wait to recheck later or increase the dose. You just got them right away on the max, on the regular replacement dose. So you have somebody who's about 60 kilograms, they need about 100. You don't start 50 and bring them back and see how it works. You just go directly full dose. Now, in subclinical, again, normal free T4, elevated TSH, you use them sub-regular dose. What's sub-regular dose? Usually between 1 to 1.4 microgram per kilogram per day. So 60 kilogram, I may start them 50. 100 kilogram, I may start them 100. And again, you're going to recheck them 6 weeks down the road. This is one thing to remember. You need to recheck them. You have to tell the patient they need to do that. Typically, once I start patient on treatment, I automatically give them a request for 6 weeks. or 5 to 6 weeks. Now, the third issue is the pregnancy. Now, of course, thyroid with the pregnancy is a major issue because a lot of women, again, they don't know that they're pregnant. They may have irregular menstruation, so delayed cycle may not necessarily know that she's pregnant. She may think it's a regular delayed cycle. Where she is pregnant, the baby, again, depends 100% on the mother thyroid for neurodevelopment in the first 30 weeks, which is really the crucial part. And so there is a lot of data to suggest, again, there's more other issues. There's increased preeclampsia. There's increased, actually, ARDS in the fetus, placental abruption, preterm delivery, low birth weight, increased C-section, postpartum hemorrhage.
Dear doctor, your time is up.
What?
Don't worry, yes.
Well, I would like to thank you all for listening to me. Okay, so, but I still, all right. I cannot do anything. You guys locked me. Anyway, so I'll speed up. Anyway. Okay. Anyway. So who you should screen for thyroid, especially in women, pregnant women. Do you have to check every pregnant woman? The answer is no. So not every woman need to have a TSH check. Who do you check? People who have a high risk to get thyroid disease. So people with areas with abnormal, significant frequency. I actually see a lot of people from, what's called, Uzbekistan and those mountainous area, they have very frequent thyroid disease. These people, maybe I'll be more likely to check them all the time. If they have symptoms to suggest, which is really hard to know, because every pregnant woman will complain of being tired. So it's really hard to know. Family history, of course, is important. And then if there is any prior history of positive antibodies, goiter, type 1, again, type 1, you need to have, male or female, they need to have their TSH checked every year at least, because again, they have 25% lifelong to get risk of thyroid disease. And then there's a radiation to the neck, they could have got radiation for lymphoma that again, can translate to underactive thyroid 10, 20 years down the road. If she had multiple miscarriages, if she has class 3 obesity, again, we mentioned that the TSH goes up as you get heavier, infertility, of course, if you have prior thyroid disease, and if you have any exposure recently to medication that can affect thyroid. It's kind of the same risk screening criteria for low thyroid. Pregnancy, you be a little bit more sensitive, you lower your threshold to check people. And again, you have to remember, there's a normal change in the thyroid physiology in pregnancy, so it is very common initially to have a lower TSH in the pregnancy. Don't get very frantic. Again, you have pregnancy-induced hyperthyroidism, and so it's very common to have a low TSH. Now, how are you going to treat this patient? So let's say you get a patient with low thyroid in pregnancy. We're going to go over that just in a second. But again, if you check them and the TSH, let's say 1.5, do you do anything? The answer is no, you're done. So you have somebody who's high risk, has mother history of thyroid disease, you check the TSH is 1.5, you say, well, your fatigue is not from the thyroid, it could be anemia, it could be you're not sleeping well, it could be your husband. Okay? If none of those conditions, it's not your problem. If the TSH over 2.5, we'll go over that. Now, if you have somebody with TSH below 2.5, do you need to recheck them again? The answer is no, except, again, there's always an exemption. Again, it's all about common sense. So if you have somebody who's very high risk, somebody who had hemithyroidectomy before the pregnancy, somebody who had radioactive ablation before pregnancy, something like that, which put them very high risk, then I may check it the same way I check somebody with actual low thyroid, which is I check them every 4 weeks initially, the first maybe 20 weeks, and then every trimester after that. So this is that people are very high risk. Now, if somebody have radioactive ablation for Graves or toxic nodule, or have thyroidectomy for Graves, they need to be monitored for other issues. And again, if you have a lady with history of Graves who got pregnant, maybe refer her to the endo because, again, we need to check antibodies. We need to see the change in the fetus because sometimes the antibodies can cross the placenta and cause fetal abnormality. Even a patient already have thyroidectomy and on, levothyroxine. So you can have thyroidectomy or radioactive iodine and on replacement, and still the antibodies can cause, fetal thyrotoxicosis. So I would say if you have somebody with Graves, pregnant, send them to endocrinologist. Now, what's your target? Again, we said we prefer the TSH below 2.5 to 3. If the TSH, let's say 3, 4, 5, what do? You check the antibodies. And I think this is one thing that's very important. You check thyroid peroxidase antibody, not thyroglobulin antibody, not TSH receptors antibody, because I see a lot of things done. Now, how do you do it? Well, it depends on their level. So I would check the TSH. If the TSH over 4, I'm more likely to treat them. Well, typically I treat them because I'm not going to wait and see what will happen. And so I'll start them on a treatment based on this. If the TSH, let's say 5 or 6, and she's pregnant again, you're newly diagnosed, so she doesn't have pre-existing disease, and TSH 5 and 6, what do? Well, you check the TSH, it's 5. You check the antibodies. The antibodies, you checked it, it's positive. You check the free T4. Again, early pregnancy, you kind of can depend on free T4. Later, you cannot, unless you have reference range for pregnancy for free T4. So if the patient has overt hypothyroid, you treat them with what? Full replacement dose, which is what? 1.6 microgram per kilogram per day. If they have subclinical, then you treat them with a lower dose. You can do 1, 1, 2, 1, 3, again, microgram per kilogram per day. Do I check them in 6 weeks later? No, I check them in 4 weeks later. Again, pregnancy is a different animal. Now, if the TSH, as we mentioned, below 2.5, we just don't do anything unless, again, they're very high risk. Then we only monitor them by checking their TSH every month, the first 5 months of pregnancy, every trimester after that. And then if it goes to the other categories, then I treat them. Now, what's about if the TSH 2.6 to 4? Again, I will look at the antibodies and I'll decide on the treatment. If I have a positive antibodies, I'm very likely to treat patient. And how am I going to treat the patient? You can start small dose, maybe 50 microgram. All right? So if the TSH 2.6 to 4, positive antibody, treat 50. 2.64, negative antibody. You have a choice of not treatment. You have a choice of treatment. Again, you sit with the patient, you explain to them the benefit and risk. Now, what's about if you have a TSH below 2.5 and you already know that there's positive antibody? I sometimes treat some patient like this. Again, do I have a strong data? There's only one study by Negro where they look at people with normal TSH and they've seen decreased recurrent miscarriages. So if I have somebody with recurrent miscarriages, even if she has a TSH2, I may treat her. You have to remember, TSH does fluctuate during the day. It's not like you have a TSH of 2 the whole time. So it depends when you check the TSH. If I check the TSH at 9 p.m., it's going to be higher than 2 p.m. So if I need to have a higher TSH for the insurance, I send the patient to draw the blood in the night. If I need a patient to have a low testosterone, I do the testosterone in the evening. I don't do it in the morning if I want a low testosterone, because what's normal range is very wide. So it depends what you're trying to do here. If you work in DHA, you can do whatever you want. Nobody's going to ask you. But when we're talking about private, sometimes they look at the lab, then this is a different story. So, again, if the TSH elevated 1.4, maybe look at, again, as we mentioned, the full replacement dose, which is, again, 1.6 microgram per kilogram. If you have, normal free T4, so it's not overt, then you do the 1 microgram per kilogram. And if you have 2.6 to 4, then you use a lower dose. Maybe you can start, again, as we mentioned, 50 microgram or so. Now, what's if you have a pre-existing thyroid? So you have somebody who have a thyroid medication. You have to remember, again, there is more diurnal vibration in the TSH. So the nadir or the trough TSH tend to be about 2-3 p.m. So again, I want the best TSH. I do it in the afternoon. I want to do higher TSH. I do it in the morning. This is the way you're going to look at it. So it does fluctuate quite a bit. And this is one thing to keep in your mind. When was the lab done? If I have my target is 2.9 or less, and I have somebody who did the TSH at 2 p.m. and their TSH 2.8, I may increase their dose anyway, even though it's on target, but it's done on the time that should be the trough TSH. I have a margin, I'll just push the dose. So again, nothing is black and white necessary. Now, how often do you check the thyroid level? Again, every month, at least the first 20 weeks of pregnancy. Then if there is no further adjustment in the dose, then every trimester or so. Again, it depends on the individualized. One thing you need to remember, if a patient finds out they're pregnant, they may not have access to health care, they may not have a way to get checked for a period of time, so you can advocate them that once you get pregnant, let's say you're taking 7 tablets of levothyroxine 100, then you increase by 2 tablets a week, so you take 1 daily and 2 on Monday and Friday, which make it 9 weekly, till they assess by you and you take it from there. So you preemptively let the patient increase their thyroid replacement dose because they found that they're pregnant, and we talked about the monitoring. Now, what's normal TSH? I do like the old American Thyroid Association normal range, which is, again, below 2.5 in the first trimester and below 3 for the second, third. Then the American Thyroid Association in 2017 backed off on those and actually raised the normal TSH to 4. But again, it's really hard. It's very vague. And so you go by patient, you go by their antibodies, you discuss with patient. And again, you have some patients who refuse taking anything. Some patients get afraid of even minimal risk increase, and they're willing to take medication. And again, you don't want to over-treat patients, so follow this kind of a dosing guideline, because again, over-treatment or thyrotoxicosis could increase the risk of preterm delivery. Now, what do you do after they deliver? Well, if somebody is already having hypothyroid pre-pregnancy, what do? You go to pre-pregnancy dose. You tell him, you remember what you were taking there, and at that time your thyroid was fine, then you go to it. Now, if this is newly diagnosed thyroid, then it's really on an individual basis. It depends when you diagnose them, what was their TSH, what were their antibodies, and are they breastfeeding? Because if they may have permanent or temporary underactive thyroid, and you want to stop the thyroid replacement, but there is a risk if you stop it and the TSH increase and the thyroid hormone drop, it will affect their breastfeeding. And so, if somebody is breastfeeding, you may maintain treatment and wait till they finish breastfeeding and stop the treatment and see how it works. And I would do that especially if the thyroid antibody is negative, because again, the risk of progression is only about 2% a year. If somebody high antibodies, then I may tell them, we have 2 choices. I can stop the treatment and see how it looks, or keep you on treatment. The only time you're going to keep them in treatment is when, if the patient comes to you, say, I delivered and I want to get pregnant again. So, some people who got married later in life and they're in a mission to have 3 kids in 3 years, then you just keep the treatment, you don't stop it, because you don't have time even to check them up, they get pregnant again. So it really depends on the individual patient and so. So if anything you need to remember, I got you very confused more. I'm actually myself very confused, what to do with pregnancy. So again, you go woman by woman, especially women. When you treat women patient, it's different than men. Separate. So you do different template of treatment. Again, look at the symptoms, look at the family history, decide if they need to be screened. Don't screen every pregnant woman. Again, whenever you order a test, you have to be ready for the result of it. I've seen a lot of people who do CAT scans and imaging for no good reason. And then they find something, and then the patient end up by doing multiple tests for this abnormality. And patient will forget why they came to be checked to start with. So patient came with, fatigue, and they had CAT scan, and then they found something, and they have multiple CAT scan. And then after 1 year later, and after 50,000 dirham of expenses, the mass is normal, and the patient still fatigued. So again, common sense is very important in medicine. And again, we talked about who need to be screened. I think at this point, if any question, that's great. If no question, I'll leave.
All right. Thank you so much, Dr. Jalal, for an excellent and comprehensive overview of hypothyroidism in different clinical settings. We're really squeezed for time, so we're going to allow just 2 burning questions.
Yes. Yes?
Yeah.
Yes, you can.
Just come and stand here so we can have your question, please. Come.
Yeah, please go ahead.
No, 2. Only 1, 2. Yeah. 6 weeks. Okay, so again, pregnancy 4 weeks. Non-pregnant 4 to 6 weeks. No. 6 weeks. The standard is 6 weeks. And you can do it earlier. Again, in pregnant women, it's different.
The lady?
Yeah,
Yes,
thank you
go
so
ahead.
much for the speech. I just would like to ask, is there any studies about the prevalence and the causes of multinodular goiter in UAE? Because
I
I've
have
seen
no
a lot
idea.
of cases in the absence of antibodies, with negative antibodies.
You
A
can
lot
have,
of-
okay, so the thyroid antibodies are non-specific. It doesn't only happen with Hashimoto. High antibodies is with a lot of thyroid condition. But we're talking checking the thyroid peroxidase only in the context of low thyroid.
Yeah.
Can you have thyroid nodule with normal antibody? Of course. Actually, if you have nodule, you don't need to check antibodies. It has no relation. I would
I mean,
biopsy.
any idea about the prevalence of the
No,
multinodular goiter
not
in
really.
UAE?
I mean, I don't know if
and the
anybody,
causes?
do you know prevalence? I have no idea.
I have seen a lot of cases, and
Yeah.
it's really...
And it depends
yeah,
where they live,
interesting.
depend on their iodine exposure throughout the life. Again, I work sometime in Marina. I see a lot of people from, old Russian Federation. All of them have thyroid
I'm
problem.
working in Abu Dhabi, and I'm seeing most of my patients are local patients.
Yeah.
That's why I'm asking.
Yeah,
Okay.
I'm
Thank
not
you.
sure. Yes, last one.
Thank you very much for the presentation. Just two questions, quick. I do have a comment first about the starting dose of euthyrox actually, or thyroxine, which is 1.6. That means that we can start with...
This is for overt hypothyroid.
That's right. So we can start with 150, for example, for
Yes,
one
if 100
kg.
kilogram, 150.
My personal experience about the side effect of a starting dose of medicine, actually, it wouldn't let the patient, most of the patient actually, to continue on the medicine. I'm not sure if there is any certain protocol that we can start it gradually over 2 weeks, for example, instead of giving 150
Okay.
as a start, yeah.
Younger, okay, so if you have abnormal TSH, you don't start patient treatment, you have to recheck. I may not mention that, but you always have to think about lab error, number one. And you have to think about this could have been, especially if patient does not have symptoms. So let's say I have a patient with TSH of 20. Patient has no symptoms. And I get abnormal TSH. I may not treat them right away. I tell them, wait 3-4 weeks, I'll recheck your TSH, free T4 and thyroid peroxidase. Because some people have thyroiditis and it normalizes by itself. So I would not start treatment right away unless, again, somebody who may get pregnant, they are very symptomatology. So it's not like everybody I treat right away. But if still the same way, I can go the full replacement dose. Now again, if a TSH is 10, you can use a little bit lower dose, again, depending on your comfort level. But when I'm trying to say don't start 25, I see a lot of people with 25, which is useless.
Okay. Second question, we know that pregnancy would increase the requirement of TSH in pre-existing hypothyroidism. So in case of low TSH, which is detected early pregnancy, carries the possibility actually of beta-HCG-induced thyrotoxicosis. Would you still increase the dose of euthyrox or thyroxine treatment?
So if somebody is pregnant, okay, if you don't have any thyroid level result at this point, I automatically increase their dose. From 7 pills, let's say if they're taking 7 to 9, okay? If I check their thyroid level and their TSH is 0.1, I may not increase it. But anyway, I'm checking them 3-4 weeks later, okay? But if I treat them and after I increase their dose, 4 weeks later, the TSH is 0.1, I don't care because this is normal pregnancy. You got what I'm trying to say?
Yeah, I got it.
Yeah.
Thank you very much.
Thank you. All right,
Well,
thank you very much.
Great. Thank you very much, Dr. Jalal, Ricardo, Dror, Hani, and Dr. Khadija for running this session. Thank you for your excellent discussions. So we covered obesity, prevalence, and talked about diabetes and medications, and we finished with hypothyroidism, lifestyle. Don't forget, focus on